begin with the presentation. I should have been that we will allow you to just give your opening remarks,
Oui,
but
bonjour,
looking
je suis
at
prêt.
the time, and there
Donc,
are people on the call already, so probably when you are starting with the presentation, then you just give your remarks and then continue with it. Thank you.
merci. Je peux partager. Est-ce que je peux avoir la main pour placer ma présentation? Ou bien c'est vous qui présentez ma présentation? OK. Voilà, merci beaucoup. Donc, ce serait bien si je peux avoir la main pour pouvoir défiler les diapos plus facilement. N'est-ce pas, Michael? Est-ce que je peux avoir la main?
Okay, 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 I'm doing that now. I'm ending it. Okay.
Merci. Donc, non, ce n'est pas encore effectif. Il faut désactiver. Ah, OK, c'est bon. Est-ce que vous voyez ma présentation?
Yes, we can see.
OK. Donc voilà, merci beaucoup de m'avoir convié à cette rencontre d'échange pour parler des droits humains dans les groupes vulnérables. Ma présentation sera surtout axée sur les consommateurs de drogue, les droits humains des consommateurs de drogue. Mais aussi, vous allez voir que c'est essentiellement cette défense des droits humains, en tout cas pour tout ce qui concerne les consommateurs de drogue, c'est vraiment arrimé au programme VIH. Parce que le programme VIH, à travers le Fonds mondial, qui nous a appuyés et qui nous a permis vraiment d'avoir des avancées importantes. Donc voilà le plan que nous allons aborder. Après l'introduction, on va parler du cadre juridique sénégalais. Et dans le cadre de ce cadre juridique, on va parler de la réduction de l'offre et de la demande, qui sont deux leviers importants de cette politique nationale de lutte contre le trafic illicite de drogue. Et à travers cette réduction de la demande, nous avons surtout une nouvelle thématique, un nouvel axe stratégique qui constitue la réduction des risques, qui constitue un impératif vraiment pour pouvoir lutter contre l'usage de drogue. Et face à ces stratégies de réduction des risques, nous sommes opposés à il y a des obstacles parce que la loi est là, la loi n'a pas été changée depuis 1997, donc il y a des obstacles vraiment qui se dressent devant cette mise en œuvre des stratégies de réduction des risques, notamment, des obstacles notamment sur le plan juridique, mais aussi sur le plan social, mais aussi sur le plan institutionnel que nous allons voir aussi. Face à ça, on a vu que face à ces politiques, nous allons voir qu'il y a des dynamiques qui se mettent en place sur le plan institutionnel, autant au niveau national, au niveau sous-régional, mais aussi au niveau international. Parce qu'on a vu qu'il y a eu quand même des progrès, en tout cas des recommandations qui sont faites de part et d'autre, et qui permettent vraiment de mettre l'accent sur cette nécessité de défendre les droits humains. C'est important de pouvoir défendre les droits humains par rapport à ces populations clés, comme on dit. Parce que si on ne respecte pas les droits, si on ne met pas l'humain au cœur de nos stratégies politiques, ce sera très difficile pour nous d'avoir des avancées ou de pouvoir être efficaces dans nos conditions, contexte de travail. Nous finirons par des recommandations sur le plan juridique, mais aussi institutionnel, avant de conclure. Donc, pour parler de la stratégie nationale de lutte contre le trafic de drogue, je l'ai dit tantôt, il y a deux leviers importants qui nous permettent de lutter contre ce trafic illicite et l'abus de drogue. Ces deux leviers importants, c'est d'abord la réduction de l'offre, faire tout pour que le produit ne soit pas disponible. Il y a des stratégies qui sont mises en place, mais aussi le deuxième levier, c'est la réduction de la demande. La réduction de la demande, c'est faire en sorte que les gens qui ont des problèmes liés à la consommation de drogue puissent être pris en charge. Et on sait que un des droits importants dans nos politiques, c'est le droit à la santé. Nous allons y revenir plus tard. Pour concerner le premier levier qui constitue à lutter contre la disponibilité des produits, c'est-à-dire la répression, l'accès répressif, on s'est basé sur deux éléments importants, notamment la Constitution du Sénégal, mais aussi le Code des drogues. Comment nous pouvons utiliser ces deux domaines importants, comment nous pouvons les utiliser pour pouvoir intervenir dans le domaine de la santé, qui est notre pilier important de travail. Concernant la Constitution du Sénégal, dans son article 8, il garantit le droit à la santé. Donc, la santé, c'est un droit. Et c'est un droit pour tout individu. Chaque Sénégalais, dans le cadre de la Constitution, a droit à la santé, à la protection de la santé physique, de sa santé physique et morale. Et cette Constitution donne la priorité aux personnes handicapées, aux personnes âgées, mais aussi aux familles rurales. Et l'État s'engage vraiment à garantir l'accès aux services de santé. Nous sommes vraiment basés sur ça pour faire en sorte que les consommateurs de drogue puissent avoir accès, comme tout un chacun, comme tout Sénégal, à la santé et à le droit. Et dans le code des drogues, notamment, nous avons un point important qui consiste l'injonction thérapeutique, parce que la loi, autant elle condamne, c'est ça aussi le paradoxe, autant la loi condamne l'usage de drogue, autant aussi l'État peut obliger quelqu'un qui consomme la drogue, c'est une mesure par contrainte, peut obliger de contraindre à suivre un traitement. Donc, c'est une mesure judiciaire qui est alternative à l'incarcération des usagers de drogue. Parce que l'usage de drogue est réprimé et interdit au Sénégal. L'objectif, c'est de vraiment un traitement médical sous contrainte. Et il y a des dispositions juridiques qui sont à l'œuvre. Cette loi sur l'injonction thérapeutique existe au Sénégal depuis 1975 et a été incorporée dans le Code des drogues qui date de 1997. Par rapport à la réduction de la demande, en dehors, je veux dire, mais en dehors de la Constitution, il y a aussi d'autres dispositions qui sont mises en place, hein, sur lesquelles on s'est basé, en tout cas, surtout au niveau international, par rapport au pacte international sur les droits civiques et politiques, qui date de 1966, qui a été réformé aussi, il y a eu des amendements en 1976, mais aussi le pacte international sur les droits sociaux, culturels aussi, qui date aussi de 1966, et qui sont des pactes qui ont été vraiment promus par les Nations Unies. Concernant la réduction de la demande, donc il s'agit d'une approche sur la santé publique qui est basée sur la santé publique, mais aussi le respect des droits humains. Et ces risques-là, et à travers ces réductions des risques, nous avons mis en avant les risques qui sont présentés par les consommateurs de drogue. C'est pourquoi je disais que cette défense des droits humains, on le verra même dans la suite, que c'est vraiment arrimé sur le programme VIH. Nous avons beaucoup travaillé avec le programme VIH et ce travail-là, cette collaboration avec le programme VIH, à travers le Conseil national de lutte contre le sida, nous a permis vraiment de mettre en avant ce droit à la santé, mais aussi les droits humains. Donc, ces risques, c'était si on ne respecte pas les droits humains des usagers, les risques, c'était si on continue la répression, ce sera un échec dans la politique de lutte contre le VIH-Sida, dans la lutte contre les hépatites, et les hépatites, que ce soit B ou C, mais aussi pour la tuberculose, parce qu'on sait que quand on réprime, on pousse les gens vers la clandestinité. Et autant plus les gens vont aller consommer dans la clandestinité, plus aussi les risques augmentent. Ce qui fait on a dit que en respectant les droits humains, on peut aussi lutter contre la progression de ces infections. Alors, comment est constituée cette politique RDR au Sénégal? Nous nous sommes basés sur les recommandations de l'ONU-SIDA, hein, et c'était ces 9 composantes. Je pense que bon, tout le monde connaît ça. Au Sénégal, on a commencé en 2011 ces stratégies de réduction des risques. Nous avons été un des premiers pays d'Afrique de l'Est francophone à vraiment démarrer ces stratégies de réduction des risques en mettant un paquet de 9 activités, constituées de 9 activités. Je pense qu'ailleurs, c'est plus, mais au Sénégal, nous sommes essentiellement basés sur ces 9 composantes que sont le programme d'échange de seringues, les traitements de substitution aux opiacés. Au Sénégal, on a opté pour la méthadone. Mais aussi, par rapport au programme VIH, rendre systématique le dépistage du VIH. Et pour ceux qui sont positifs, on les met sous traitement antirétroviral. La prévention aussi et le traitement des infections ou des maladies sexuellement transmissibles. La distribution de préservatifs pour les consommateurs de drogue, mais aussi leurs partenaires sexuels. La communication pour un changement de comportement qui est ciblé vraiment sur les consommateurs de drogue, la vaccination, le diagnostic et le traitement des hépatites virales, que ce soit hépatite B, hépatite C, etc. Mais aussi par rapport à la tuberculose, la prévention, le diagnostic et le traitement de la tuberculose. Face à la mise en œuvre de ces 9 composantes, il existe des obstacles. Et ces obstacles-là, c'est surtout sur le plan juridique que nous avons ces obstacles. Hein. Donc, parce qu'au regard de la loi, autant la loi interdit, mais aussi la loi dit, mais pour ceux qui sont dépendants, on peut les traiter. Mais face à la mise en œuvre de ces stratégies de réduction des risques, nous, il y a des soucis, des obstacles, notamment par rapport au programme d'échange de seringues, qui peuvent être considérés parce qu'il y a un article dans la loi, dans le code des drogues, qui condamne la mise à disposition. En tout cas, dans cet article-là, le fait de mettre à la disposition de distribuer des seringues peut être considéré comme une facilitation à la consommation et qui peut être réprimée. De même, la distribution de préservatifs aussi peut être considérée comme une incitation à la débauche. En tout cas, les agents d'application de la loi, le problème, voilà, c'est ça. On constate des infractions, on recherche les auteurs et on essaie d'avoir des preuves et mettre les mises en cause à la disposition de la justice. Donc, ça, on nous le disait hein, quand on commençait ce travail RDR. C'est, voilà, on est là pour appliquer la loi. Tant que la loi n'est pas changée, on va être obligé d'appliquer la loi. Et après, il y a eu des négociations qui font que c'est toléré en attendant que cette loi puisse être changée. Alors, en gros, c'est quoi les problématiques des consommateurs de drogue? Pourquoi essayer de défendre ce droit à la santé qui fait partie des droits humains aussi? Donc, c'est une population qui est extrêmement exposée au risque hein, et qui sont à l'origine de la majorité des cas de nouvelles infections. L'étude réalisée en 2011 avait montré des prévalences qui étaient 4 à 50 fois plus élevées qu'en population générale, quand on prend les groupes vulnérables. D'où ce paradoxe qu'il faut faciliter l'accès aux services de prévention. Et face à cette facilitation de l'accès, on sent que la prise en charge est très faible. La problématique des CDI, voilà les conséquences, c'est que 5,2% pour montrer que c'est des prévalences très élevées. Chez les consommateurs de drogue injectables, c'est ce qui concerne l'héroïne, la cocaïne, le crack, quel que soit le mode de consommation, la prévalence du VIH était à 5,2%. C'est les injecteurs, si on prend ceux qui s'injectent, effectivement, la prévalence monte à 9,4%. On voit qu'il y a une discrimination entre les hommes et les femmes. Chez les hommes, c'est 6,8%, mais on voit que chez les femmes, c'est 28,6%. Donc, les femmes sont beaucoup plus exposées que les hommes. Donc, les femmes infectées, c'est 4 fois plus que les hommes. Ce qui peut l'expliquer, c'est l'association sexe-usage de drogue. Les gens qui consomment voilà, des drogues peuvent aussi recourir au commerce du sexe pour avoir de quoi alimenter leur consommation, mais aussi parfois ils sont sous l'emprise d'un homme qui les oblige à se prostituer. Alors, les problématiques de ces populations clés, c'est cette difficulté d'avoir des informations pour orienter les politiques. les stratégies et les interventions, la stigmatisation et l'autostigmatisation, parce que l'autostigmatisation aussi est très importante, un environnement socioculturel qui est hostile chez les populations, de façon générale. En tout cas, c'est des difficultés ou des situations que les consommateurs de drogue partagent aussi avec les autres consommateurs, avec les autres groupes vulnérables, que sont les hommes qui ont des rapports sexuels avec les hommes, le travail sexuel, mais aussi même les populations particulières, notamment les détenus. Cette stigmatisation sur laquelle on revient, c'est, voilà, constitue vraiment un gros fardeau et qui peut prendre de nombreuses formes: manque de respect, attitude moralisatrice, hein, hein, ce que vous faites là, c'est pas bon, on juge, on est dans le jugement ou bien dans le dénigrement, parfois même négligé, ou bien on leur propose des soins qui ne sont pas adaptés, refusés ou prodigués avec beaucoup de retard, ce qui constitue vraiment des freins majeurs au recours durable à la prévention et au traitement. Les conséquences, c'est que cet environnement hostile à l'accès aux services de prévention, les freins des activités du programme à l'endroit des consommateurs de drogue, une baisse de la performance du programme qui va entraîner des ruptures dans les traitements et les soins et des prises de risques des gens qui s'adonnent à la polyconsommation ou à la consommation de nouvelles substances. Actuellement, la substance qui fait fureur au Sénégal, par exemple, et en Afrique de l'Ouest, certainement, c'est le couche. Il y a de nouvelles substances qui émergent et qui sont très consommées et qui entraînent de lourdes comorbidités. Parfois même, voilà, les consommateurs sont confrontés aux overdoses et qui entraînent une augmentation de la mortalité. Voilà, là, c'est une situation qui décrit un peu, voilà, comment nous sommes parvenus à un contexte où il n'y avait pas de données, au contexte où on a eu des données et qui a permis vraiment de mettre, l'idée c'est vraiment de montrer, de mettre en évidence l'existence de cette population clé que constituent les CDI et de mettre en place un programme de prise en charge, ce qui a été fait au Sénégal avec le CEPIAT qui a été ouvert en 2014. Voilà, depuis l'ouverture de CEPIAT, il y a eu des opportunités. Des opportunités, voilà, se sont montrées, ont été, voilà, mises en évidence. Des opportunités, c'était avec l'ouverture du CEPIAT, on a vu que les autorités ont réagi. Bien vrai que voilà, l'environnement juridique n'a pas été modifié. On a vu des autorités vraiment qui s'engagent pour encourager le travail qui est en train d'être fait. Et même le président, au Conseil des ministres de 2016, disait qu'il nous faut adopter un plan d'action national. Ce qui a été fait dès 2017, il y a un programme qui a été mis en place, qui a été adopté, la mise en place du CEPIAT, l'ouverture du diplôme universitaire d'addictologie à la faculté de médecine de l'université de Dakar, hein. Les liens qui ont été établis entre la consommation de drogue, c'était montré à travers cette étude, les liens entre consommation de drogue, VIH, hépatite et tuberculose. Ce qui rendrait impérative la mise en œuvre d'un programme de réduction des risques pour préserver la santé publique. La sensibilisation du large public à certains moments, certains événements, mais aussi le dynamisme des organisations de la société civile qui ont vraiment permis au programme de se développer et même de s'étendre au-delà du Sénégal. Par exemple, avec le programme Pareco, qui est un programme de réduction des risques au niveau de la sous-région qui a concerné 5 pays et qui a été promu par l'ANCS, mais aussi l'élaboration d'une politique africaine, ouest-africaine sur le programme mondial des drogues, avec OSIWA, mais aussi avec la fondation Kofi Annan, et qui ont permis vraiment à certaines structures, dont WAXI, mais aussi WADPN, qui est actuellement en train d'organiser cette rencontre. Une dynamique internationale aussi sur le plan sous-régional, mais aussi sur le plan régional et multilatéral. Ces opportunités ont permis de saisir les partenariats existants pour améliorer euh, l'environnement, notamment avec la collaboration du ministère de la Justice, du ministère de l'Intérieur, des organisations religieuses, la convention avec les médias, les associations de jeunes, et qui nous permettent aussi d'aller vers de nouveaux partenariats, notamment avec le centre de formation judiciaire qui forme les magistrats. C'est des agents aussi d'application de la loi qu'il faut sensibiliser par rapport à la problématique des consommateurs de drogue, les organisations des droits de l'homme, les parlementaires aussi qui vont voter les lois, mais aussi surtout les influenceurs pour donner plus de voix. C'est ainsi que des propositions ont été faites par rapport au Code des drogues, qui date de 1997, autant sur le plan législatif que sur le plan réglementaire. Sur le plan législatif, on a demandé une modification de certaines dispositions du Code des drogues. Et cela depuis 2017. Ces projets de réforme sont disponibles depuis 2017, mais au Sénégal, ça tarde encore à être validé. Donc, modification, notamment l'article 98, par rapport à la facilitation de l'usage de drogue, le fait de donner des seringues. Donc, on demande à travers cet article modifié l'exemption de la responsabilité des personnes qui mettent en œuvre un programme de réduction des risques. Donc, quelqu'un qui intervient dans le cadre du programme ne doit pas être considéré comme quelqu'un qui facilite la consommation. Idem aussi par rapport à l'article 120 aussi du Code des drogues, qui concerne aussi l'injection thérapeutique. Des propositions ont été faites pour sa mise en œuvre, parce qu'on voit que depuis lors, ça n'a pas été mis en œuvre pour des raisons bien concrètes. Sur le plan réglementaire, nous avons aussi proposé de nouveaux textes réglementaires, notamment un décret sur la réduction des risques. Il faut vraiment qu'il y ait un cadre juridique par rapport à la réduction des risques qui permet l'identification des personnes, parce qu'on a dit que les personnes qui interviennent dans le cadre du programme ne doivent pas être considérées comme des facilitateurs. Hein, ne doivent pas être considérés comme des facilitateurs. Donc, par conséquent, ils doivent être identifiés comme des gens intervenant dans la mise en œuvre du programme à travers des badges. Il faut aussi un arrêté conjoint du ministère de l'Intérieur et du ministre de la Santé, après avis du comité interministériel de lutte contre la drogue, pour fixer les conditions et les modalités de délivrance des badges, et un arrêté conjoint du ministère de la Santé et du ministère de l'Intérieur pour arrêtant la liste des structures appliquées, euh, qui met en œuvre ces programmes de réduction des risques. Alors, pour les justificatifs parce qu'il y a un plan quinquennal des droits humains concernant les populations clés qui est en train d'être mis en œuvre par le Conseil national de lutte contre le sida. Et il y a des justificatifs, il y a en tout cas un support qui permet de justifier la nécessité de mettre en place ce plan quinquennal. D'abord, il y a le rappel de la stratégie du Fonds mondial pour 2017-2020 qui incite à mettre fin aux épidémies, à investir pour mettre fin aux épidémies, mais aussi d'augmenter les investissements dans les programmes visant à éliminer les obstacles liés aux droits humains. Donc, c'était une recommandation du Fonds mondial et que le CNLS est en train de mettre en œuvre. Les programmes essentiels pour favoriser les populations les plus touchées par les 3 maladies que sont le VIH, les hépatites, mais aussi la tuberculose. Donc, on recours accru aux services de santé, une meilleure rétention, donc rétention des gens. Il ne s'agit pas seulement de recruter, mais les gens qui sont recrutés doivent être aussi maintenus dans les programmes, doivent rester pour le suivi. Un axe stratégique prioritaire du plan de lutte contre le sida, qui est la mise en place d'un comité de pilotage pour le suivi, pour la coordination et le suivi des interventions. Ces interventions du plan quinquennal, c'est axé sur la lutte contre la stigmatisation, parce qu'on voit que c'est un grand problème sur la répression du côté social, l'acquisition des notions de droits et services juridiques, l'aberration des lois et des textes réglementaires, et des politiques relatives au VIH et à la tuberculose, sensibiliser, responsabiliser et engager les acteurs de santé. Sensibiliser et responsabiliser et engager les forces de l'ordre, les agents d'application de la loi, les acteurs judiciaires, l'administration pénitentiaire et les législateurs, le renforcement de la dimension genre. Ça, c'est important aussi dans la défense des droits humains et la réponse au VIH et à la tuberculose. Et aussi la coordination et la promotion, le suivi et l'évaluation des réponses multisecteurs, parce qu'il faut qu'il y ait un suivi pour voir à quel niveau on se trouve et quel est le niveau d'impact. L'élaboration d'un référentiel droits humains, c'est important aussi dans la réponse du VIH. Tout ça aussi, c'est dans le cadre du programme VIH aussi, qui consiste à mettre en œuvre, à mettre à la disposition des acteurs de lutte contre le sida un document de référence pour servir de cadre de mise en œuvre de la politique nationale. Ce contenu, qu'est-ce que va contenir ce référentiel? Donc, ce sont les textes internationaux et africains. J'ai parlé tantôt des pactes internationaux là, sur les droits civils et sociaux, mais aussi sur les droits politiques de l'ONU, sur lesquels nous sommes beaucoup appesantis. réexaminer le cadre juridique. J'ai dit tantôt que depuis 2017, il y a des réformes qui sont en cours, qui sont demandées, mais qui ne sont pas encore validées sur le plan politique. Démontrer que la lutte contre le VIH aborde des aspects très sensibles. Les interventions des acteurs de la santé doivent être essentiellement basées sur le droit à la santé. C'est ça, c'est le premier droit. Moi, je parle de droit à la santé, c'est le premier droit. Les documents donnent une orientation sur la manière de mettre en œuvre les programmes des droits humains. Alors, quels sont les défis? Les défis, nous allons les voir à 4 niveaux. Donc, c'est la formation juridique et éthique sur le VIH, l'accès limité à la justice et au recours. Donc, on constate qu'il y a une faible connaissance des droits par les populations. Avoir une communication et des interventions adaptées au contexte, ça aussi c'est un défi pour éviter la stigmatisation et une meilleure compréhension de la mission de santé publique par la population générale. Et enfin, il s'agit aussi de lever ces obstacles dont on a parlé tantôt pour promouvoir un environnement favorable à la réforme, mener des plaidoyers et accompagner les populations clés pour la protection et la connaissance de l'œuvre. D'autres défis aussi existent, c'est le manque de structures et de médecins spécialisés, la réticence judiciaire, où les consommateurs de drogue sont encore considérés comme étant des délinquants. Le terme même qu'ils utilisent, c'est toxicomane, qui est un terme assez péjoratif et exclusif qui est encore utilisé. Et il y a cette dichotomie entre toxicomane et délinquant. Et aussi ces incohérences législatives qu'on a relevées et qui font qu'on a demandé des modifications des textes de loi. Les recommandations, c'est la réforme de l'article 120, on en a parlé tantôt, et du décret de 97, la mise en place de médecins de relais et sensibilisation des officiers de police judiciaire et une meilleure prise en compte des usagers vivant avec le VIH. Quelques pistes d'action sur lesquelles nous devons nous appuyer aussi, c'est d'abord intégrer une approche fondée sur les droits humains, ça on l'a dit tantôt. Si dans le cadre de ces programmes, on ne met pas l'accent sur les droits humains, c'est sûr que nous n'allons pas réussir tous les programmes, que ce soit les programmes de lutte contre le VIH, la tuberculose, les hépatites aussi. Le respect des droits humains, c'est fondamental pour pouvoir réussir les différents programmes de maîtrise des épidémies. Soutenir les programmes d'éducation juridique communautaire, il faut que les gens connaissent les droits, leurs droits, etc. Contribuer à la mise en place de jurisprudences protectrices en matière de VIH et de populations vulnérables et participer aux initiatives intersectorielles pour créer un environnement juridique propice à une réponse efficace au VIH. En conclusion, nous dirons que certes des progrès réels ont été faits, mais les défis restent encore importants, rendant nécessaire des réformes juridiques et une mobilisation des acteurs afin de mettre les droits humains au cœur de nos politiques. Nous allons terminer en reprenant cette citation de Kofi Annan, hein, qui disait que j'espère que la santé ne sera finalement pas considérée comme une bénédiction à souhaiter, mais comme un droit de l'homme pour lequel il faut lutter. Je vous remercie de votre attention.
Thank you very much, Dr. Ba, for this
Ouais.
wonderful presentation. Before we move to the other speaker, I would like to ask if there is any questions or any comments with regards to Professor Ba's presentation. The floor is open if for a few questions, probably maybe 2 minutes, then we move to the other speaker.
Oui, allô?
Okay, yeah, hello.
Oui, bonjour, je n'ai pas pu lever la main, mais si je peux réagir à l'intervention maintenant.
Yes, please, you can.
D'accord. Merci beaucoup. Je suis Alain Kra, je suis de Côte d'Ivoire, juriste consultant et intéressé par donc toute cette problématique de l'approche humaine pour la réponse à la problématique des UD. et félicite aussi le professeur pour son intervention et pour l'exemple du Sénégal qui a inspiré beaucoup de pays, notamment la Côte d'Ivoire, ces 2 dernières années, qui suit un peu cette dynamique juridique et législative au Sénégal. Sur ces recommandations, et le professeur a parlé de mettre en place une jurisprudence pour justement aider à faciliter les décisions de justice. Je voulais peut-être ajouter documenter la jurisprudence qui existe déjà, parce que très souvent dans nos pays, il y a des décisions de justice à l'intérieur du pays, dans les tribunaux qui sont dispersés, et on n'arrive pas à capter, mais des magistrats rendent des décisions intéressantes, importantes, qu'on n'arrive pas à capter. Donc, à côté peut-être dans la mise en place de cette jurisprudence, c'est de compulser les documents qui existent, compulser, documenter les décisions de justice à travers les tribunaux, et en faire des recueils, des guides à l'attention des professionnels du droit. Parce que je suis sûr qu'il y a des bonnes choses qui sont déjà faites par des professionnels du droit, on les sensibilise, mais il y a des décisions de justice qui sont rendues et très souvent nos pays, on a du mal à capter, à les compulser, à les regrouper et pour en faire la publicité. Donc, c'est ce que je voulais ajouter. Si sur le point de la mise en place de la jurisprudence, ça va avec compulser et documenter les décisions de justice sur l'étendue du territoire qui traite la question des UD. Merci beaucoup, professeur, pour ton intervention.
All right, thank you. Thank you very much for your comment.
Merci beaucoup, Alain. Bon, je pense qu'Alain a fait plus... Je peux prendre la parole? Oui, non, c'était pour...
Yes, please. Yes, please.
Remercier Alain pour son
minute.
intervention, qui est plus une contribution. Et je pense que tout travail aussi, c'est comme ça. Il faut partir de l'existant. Et c'est à partir de l'existant qu'on peut voir s'il y a des insuffisances, s'il y a des choses à compléter, s'il y a des choses à améliorer, etc. Donc, tout ne vient pas comme ça, ex nihilo, hein. Il y a toujours un support, une base sur laquelle on devait pas. Par rapport à la modification de la loi du Code des drogues, surtout l'article qui concerne l'injonction thérapeutique, on a vu que c'est une disposition juridique qui a été mise en place depuis 1975, mais qui a été très peu appliquée. Donc, nous sommes pas partis sur cette base pour dire qu'il y a quelque chose peut-être qu'il faut améliorer, parce qu'on a vu que quand même c'est une avancée, le fait de mettre en place cette politique d'injonction thérapeutique, mais ce n'est pas une panacée. En soi, il y a de bonnes intentions, mais la mise en œuvre pose problème. C'est pourquoi on a fait des propositions quand même pour faciliter la mise en application. Bon, c'est un exemple de faire l'état des lieux avant de pouvoir faire des propositions.
Exactement. Exactement. Merci pour ça.
Okay, thank you very much, Professor Abba, for adding that. So we would like to move to the next presenter, which I already mentioned. She is the Executive Director for Student for Sensible Drug Policy Network International. So, Charity, please, the floor is yours.
Thank you so much, Michael. Thanks so much, Michael. So, hi, everyone. As Michael has mentioned, I am Charity Munareng. So I'll be presenting on human rights advocacy in general in Africa with some specific examples from different parts of the region where we are starting to see progress. Okay, so just a brief about who SSDP is or who we are. So we're the largest grassroots network of students and young people advocating for sensible drug policies with chapters in over 20 countries. We work to empower young people, engage in advocacy, and essentially promoting harm reduction and human rights-based strategies. So why is actually human rights advocacy important and why it matters? So human rights are the foundation of dignity, equality, and freedom, yet often disregarded in policy, especially towards marginalized communities. So the powerful thing about human rights is that they are universal and non-discriminatory. They belong to each person automatically, irrespective of gender, age, race, nationality, or health crisis. States do not grant people human rights. They just have an obligation to respect, protect, and fulfill them. However, and unfortunately, people who use drugs, sex workers, and people from the LGBTI community are still excluded, criminalized, and stigmatized. So in this presentation, I will be exploring the evolving landscape of advocacy in Africa mostly, and how we can collectively shift from punitive responses to people-centered policies. So these are some of the human rights that relate to drug policies. So the right to life, the right to freedom from discrimination, the right to education, the right to self-determination, the right to participation, fair trial, liberty, and the right to freedom from torture or cruel or inhumane and degrading treatment. So these are just some of the key human rights and public health instruments. So we don't operate in isolation as people who advocate for the rights of people who use drugs in other marginalized communities, but we also do have some international documents that can support our work in advocating for human rights across our respective countries. So we have the Charter of the United Nations, and this is the constituting document of the UN, and it enshrines the binding commitment of signatories to health, human rights, and fundamental freedoms. This commitment overrides any obligation under other international conflicts where there is a conflict, and this means that the drug control conventions should be implemented in such a way as to be congruent with the health and human rights commitments enshrined in the Charter. We also have the International Bill of Human Rights, which it consists of the Universal Declaration of Human Rights, the International Convention on Civil and Political Rights, and 2 operational protocols, which are annexed, as well as the International Convention on Economic and Social Cultural Rights. And I'm sure most of our countries also have Bill of Rights and constitutions as well. So the next one is the Declaration of Commitments on HIV/AIDS. And this is a document that was established by UNAIDS to respond to the HIV pandemic. It is a collaborative effort consisting of 10 UN agencies, including the UNODC. And then the last one is the Constitution of the World Health Organization. And this is basically, it proclaims the enjoyment of the highest attainable standard of health to be one of the fundamental pillars of human rights. So some of the key progresses that have happened in human rights and drug policy. So it's great to hear about the progress that has been made in Senegal. And it's also always amazing to hear about the great work that colleagues are doing in West Africa. And people from Southern Africa and Eastern Africa, we always look up to Western Africa to learn more about some of the progress that you guys have been doing. So in Ghana, for example, we have started seeing a shift from there's someone's mic that's on. Michael, can you please mute someone? There's yeah, if you're able to. So we are starting
let
to
me do that.
Yeah, thanks so much. So we are starting to see a shift from punishment to public health in a lot of countries. So for example, in Ghana, Narcotics Control Commission Act recognizes drug use as a health issue and has introduced treatments and fines and not imprisonment. In South Africa in 2018, the Constitutional Court ruling that decriminalized cannabis for private use, where people are now able to cultivate in their personal homes and also use for their private purposes. In Kenya, Mozambique, Senegal was shared. We are starting to see a growing harm reduction pilots in the respective countries. We are also starting to see more visibility in civil society. So regional platforms like the WADPN, African Civil Society Platform on Drugs, and the Support Don't Punish initiatives, where civil society is starting to actively start raising awareness without fear. We are influencing policies and also building coalitions across the region. And so even though we don't only operate internationally, even regionally, we do have some political will. So for example, in the Africa Union Plan of Action on Drug Control, the 2019 to 2023 was the first Africa Plan of Action that actually had or included harm reduction explicitly. And also we are starting to see the emergence of the Eastern and Southern Africa Commission, who have openly endorsed decrim and spoken about the importance of prioritizing people's rights, shifting towards evidence-based interventions and respecting rights frameworks. So even though we have seen progress, there is persistent challenges undermining the progress. So there's still criminalization, which still dominates drug use and sex work. And we're also seeing now LGBTI communities are also criminalized in countries like Uganda. And these are still seen as moral failings. And they have resulted in the over-incarceration of people who use drugs, sex workers, and people from the LGBTI community, police brutality, as well as stigma. Weak reform implementation. So we do have some progressive laws and policies. However, they're not resourced or politically prioritized. There's also limited access to harm reduction. There are fewer African countries that offer needle syringe programs and opiate substitution therapy. Even though we are seeing progress, there still isn't, it's not enough to meet the need. We also are dealing with cultural, religious, and political resistance as the main barriers to ensuring that harm reduction is accessible and implemented. Donor dependence and poor data. I think we've all felt the impact of the US funding cuts, and this has been something that we have as civil society been advocating for with our governments to try and mobilize domestic funding, where we have been aware that any day an international funder can literally decide overnight to stop funding, and that will have major implications. And we are starting to see that in real time with the US funding cuts. So services are donor reliant. Most harm reduction services are donor reliant, and there's no sustained local investment. Lack of national data undermines visibility and policy justification. A lot of our governments are in denial that the prevalence or extent of drug use is not as bad because there is no national data. Most of us operate on national estimates, which is a disservice because we're not necessarily addressing the issue to the scale that it needs to be addressed. We are starting to see a shrinking civic space and gender exclusion, so crackdowns on civil societies, so organizations that either work with people who use drugs or the LGBTI community tend to be criminalized or arrested or harassed. And also women's LGBTI and people who use drugs voices are in some cases sidelined in reforms. There's also insecurity and limited regional enforcement. So we have been seeing some wars, insurgencies, and also the weak enforcement of rulings, which have eroded human rights frameworks. So what do we need to change the way that we're doing things, or in order to achieve reform? So we need legal reform and decriminalization. We need to end criminal penalties for people for personal use and sex work and other marginalized activities. So decriminalizing poverty, essentially. We need to recognize human dignity in law. We need domestic funding in services. The US funding cuts have taught us a major lesson as Africa, and we basically just need to ensure that governments are investing in community-led approaches so that communities are empowered, communities also have ownership on services. We need culturally sensitive harm reduction and support services. So harm reduction in South Africa might look very different to harm reduction in Senegal or Sierra Leone. And so we need to ensure that they are culturally sensitive. They also might be different within different regions within respective countries. So urban harm reduction services might look very different to rural harm reduction services. We also need capacity building. So training police officers, judges, and social workers on rights-based health-first approaches. So trainings that have happened, for example, in Ghana, where judges and the judicial system have been trained on policy reform. In South Africa, for example, we have been doing ongoing trainings with police officers where they treat people who use drugs or any other marginalized communities with dignity. So instead of violating them, we also inform them on like harm reduction services that are there, so that people, when people who use drugs are in contact with law enforcement officers, they're not necessarily sent to holding cells. They are rather sent to facilities where they can get the help they need. We need regional collaboration, share lessons across borders. This is one of those platforms. You also need more platforms like this where we're able to share best practices and also learn from each other. Aligning with the Africa Union and other regional body frameworks. There are amazing documents and instruments that are progressive and really prioritize human rights. And we need to ensure that our governments are doing the same. And we also need to institutionalize inclusion. So we need to make people who use drugs, sex workers, and LGBTI communities part of official policy processes. So nothing about us without us must become more than just a slogan. It has to be systematized in governance. So in putting people first, the core principles of a human rights-based approach to drug control are about dignity and non-discrimination, the right to health, proportionality in sentencing, as well as freedom from torture and inhumane treatment. So ensuring that we are really integrating human rights into all national policies, so health, education, drug control, and security. We need to strengthen grassroots organizations. A lot of the progress that we have seen is because of peer-led efforts and community-based efforts. And so we need to ensure that we are strengthening those grassroots organizations and individuals. We need to enhance accountability mechanisms, so empowering human rights commissions, enforce ECOWAS and other regional court rulings as well. We need to protect human rights defenders in countries where people or civil society organizations, journalists and whistleblowers are harassed and even made to disappear. We need to ensure that there are laws that shield journalists, whistleblowers, and human rights activists. We need to expand access to justice. So we do operate under the assumption that people that we work with are aware of their rights. So we need to ensure that there's legal aid, there's mobile justice centers and community level legal education where people are educated and intentionally educated on their rights, so that in the case where they find themselves in trouble with the law, they're able to have exchanges where they talk about their rights. We also need to improve data and monitoring. Evidence should guide action because data does save lives. So ensuring that we are collecting data, governments are investing in research to get prevalence numbers rather of the extent of drug use. And so in the future of human rights in Africa lies in community-led action, radical inclusion, and regional accountability. So if you would like to stay connected with SSDP, that's our email address, our website, social media. Thank you so much.
Thank you very much, Charity, for this wonderful presentation. It's kind of like linked to almost everything that we do. The region is actually not in isolation. What is happening in the southern sector is equally happening in the West Africa region, as you mentioned, that progress in each region may not look the same, but then it's kind of an effort that we can all make sure that we are making the human rights a very priority for these three communities. That being said, I would like to open the floor for any questions or comments, if there is any.
Yeah, good morning.
Good morning.
Yeah, good morning. This is Habib Tago Kamara from Sierra Leone. Working with drug users, more especially providing harm reduction support for drug users. I just want to commend the past speaker who presented it is fact as currently the way how narrative is going. harm reduction in Africa is being donor-driven. It's being donor-driven, and it is hard times for us to start advocating to our governments for our governments in terms of investing domestic financing. As she rightly said, you can sleep tonight, tomorrow a donor will cut he or a donor to that country. So as Sierra Leone, this is currently my move now to government and to the private sector, that with the current constraints that is going on, because we used to have from the Global Fund and the PECFA funding supporting our harm reduction. So in January, first week in January, we were asked on the PECFA grant to stop work. So in April, we were called again to start work. And the year was supposed to close on July 31st, based on the current. But yesterday, we have been notified as a country on the PECFA grant to continue until end of September. So after September, what is the way forward? So as the Sierra Leone harm reduction, there has been support from the government, even for giving us an enabling environment of reaching out with our harm reduction commodities to the users. But with the Global Fund, we are currently on the reprioritizations of activities, more especially life savings activities. But with certain PRs, which are the principal recipients that are managing the funds, do not really know much about the key population interventions. Like currently, Sierra Leone, with the current grant, which is the GC7, we have a new PR, which is the World Vision International. And they don't know much about harm reduction. So we are craving an indulgence of our government and other stakeholders that we need to do more especially in Sierra Leone. We are trying to advocate for us to have harm reduction included in our national drug law, which the government will soon start to review that act. So the 2008 Drug Act came into being when the cocaine plane landed from Venezuela to Sierra Leone. By then, we were not having any drug law for the government to be able to try those that came with the cocaine plane. And that act came under a certificate of emergency, which civil societies, organizations, and other like-minded people were not on board. So from 2008, since that act came in, we raised an attention that that act is discriminatory to the users. But with the current scenario in country and the current platform, most that are in the helm of affairs of drug regulation or drug-related issues, no more harm reduction. And it's more multi and sectorial approach, which the Ministry of Health that I'm working with for the HIV response, we want that to be, and in the last and in the just past illicit drug trafficking, that was my message to the country authorities that we need to prioritize harm reduction. And harm reduction in Sierra Leone is moving well. Since inception, we incorporated the police. We have an MOU with the police that whenever they met our staffs, they don't arrest them. Since inception, there has not been any interruption. So we just want the government and other like-minded Sierra Leoneans to start thinking about domestic financing. Now, naloxone will soon start to implement naloxone in the country. Naloxone has been bought by the Global Fund, and it was bought by PECFA again. The drugs are in country. We have trained community workers in terms of naloxone. And again, the last we did a test on naloxone on Kush, and one of the recommendations. Yes, sir.
Okay.
Yes, sir.
So I think we would have to reserve this for the next presentation after it's done. But then, thank you very much for this information.
Okay. Well, thank you. Thank you.
Okay. So, if colleagues, if anyone has any comment or question, just a quick one. Charity would like to take a leave of us to join other meetings, so you can make it brief before she leaves. Okay, I guess there is no comment or probably question. Okay, Charity, I can see you from mute yourself if you have anything to add.
No, I just wanted to say thank you so much for this. And yeah, thanks for creating this platform for us to share and learn. Yeah, I do have to drop off, but if people have questions, please feel free to share my email address with participants.
Okay.
Thanks, everyone.
All right, sure. Thank
Bye.
you. Thank you very much. Okay. All right. So that being said, we would like to move to the next speaker, which I mentioned that his name is Prince Bull Lucini. Most of us who have gathered here know him as the Executive Director for the West Africa Drug Policy Network. He is now the Deputy Executive Director for the Sierra Leone National Drug Enforcement Law Agency. I would like to leave the floor to him to give us a presentation on the pathway to putting people first. Thank you. Please take over.
Good morning, everyone. And thank you, Michael, for the introduction and the opportunity to speak to this subject and to join my colleagues, Dr. Ba and Charity, whom I know have done a great job with regards to human rights advocacy in West Africa, particularly for minority groups. So thank you very much. Michael, I just want to confirm that my voice is loud enough and the presentation is visible, right?
Yes.
Yes,
it's also visible.
Oh, thank you. Yeah, so I want to thank Dr. Ba and Charity. I guess they may have presented some statistics. They may have presented some facts. Of course, I followed Dr. Ba's presentation about their intervention and some of the challenges. And of course, Charity gives a background to what they have done, some of the progress we've made so far, and some subjects around the principle of nothing for us without us. I mean, of course, when I saw the team, I knew we were going to have some in-depth knowledge from these people. So what I decided to do was to try and focus on the pathways to putting people first. I mean, Charity mentioned, and Dr. Ba himself, some of the interventions from the West Africa Drug Policy Network and some of the things we have been doing. So I decided to focus on pathways, some of the principles to the pathways to putting people first. Just elementary concept. This definitely will target all of us on this platform, I guess, but to also help us mobilize vulnerable groups and how we can ensure that these people are not left behind. So I'm focusing on pathways to putting people first. I want to talk about the concept. The concept of putting people first is actually, as the words themselves sound, to prioritize the well-being, needs, and happiness of people in various contexts. It could be a workplace context, it could be communities, it could even be in a personal relationship. It is just caring about the well-being, the needs, and happiness of people, right? So the concept continues to inform us that it's also about treating people with respect. How do we value the contribution of people? How do we listen to them and hear what they are saying? And make sure we understand what they go through, we understand what they face in life, and we use that for advocacy, right? For the inclusion into programs, into policies, into projects. We want to value, and that's one way they know that we value their contributions. So that's the concept of putting people first. To also foster an environment where they feel supported, not criminalized, not condemned, not punished, but they feel empowered to thrive, to maximize, to actualize their potentials. So that's the concept of putting people first. We create an environment, we listen to them, we treat them with respect. Don't judge them. That's what the concept is talking about. So putting people first, like I've been saying, emphasizes a shift. I mean, even in corporate institutions, it's a shift from a system and structures to focus on individual. Now, some organizations, for example, that are policy focused, they are hierarchy focused, right? Some are policy focused. But here we're talking about individuals. We're talking about communities that we are meant to serve, especially those of us who are currently attending the program. So this concept and campaigns and initiatives have been used, or slogans like Charity mentioned earlier, they've been used in different contexts. I mean, most frequently, the HIV/AIDS campaign would use putting people first, but it can be used in different aspects. So what we are talking about today, the context is West Africa. So putting people first in West Africa, I followed Charity's presentation, and I could see a list of legislations that she presented. It has to do with human rights and advocacy and all of that. But this one is focusing really on West Africa. So when you are putting people first in West Africa, some of the things you begin to consider are agencies, regional agencies. You want to talk about ECOWAS, you want to talk about West Africa Health Organization, you want to talk about the Mano River Union. So there are agencies, there are regional agencies that you would have to consider. You also have to consider sovereignty, the jurisdiction. I mean, what may be happening even though they're all in the same block, in the same sub-region, what may be happening, or what may be happening in one jurisdiction might not in the other jurisdiction. So these are considerations we have to take in place. We also have to think about legislations, what laws exist, what's the culture, what's the tradition, how would religion affect putting people first, this class of people, right? This group of people, how will it affect them? Is this a kind of religious environment where the concept of putting people first, and these people that want to put first, whatever the context is, will it affect them? And we also have to think about the minority. So the content, the human rights, of course, we all know about human rights. Charity have spoken about it. Dr. Bass spoke about it. These are fundamental rights and freedom that belong to every person. The fact that you're just a human being is inherent, is not granted. Yet we have to advocate for them. So that's the context in which we talk about putting people first. So we want to put people first in our human rights advocacy in West Africa, which the West Africa Drug Policy Network, the SSDP, and other organizations have been doing. So I will now come to the basics, right? When you want to put people first, some of the things that some strategies you want to talk about, you want to consider. Education is key, raising awareness is key about the challenges that are facing that particular group that you want to put first. You can do this in organized workshops, you can have radio talk shows, television, social media campaigns. Just to raise awareness is key. Educate the public about what is affecting them. So in our case, we have been putting out awareness and campaigns about decriminalization of drug use, because we know people who use drugs, like Abib mentioned earlier, there are legislations that are discriminatory or put people who use drug in a position where their freedom is restricted. So we have to educate people. I think the other one should be advocacy. We support policies and initiatives that promote the rights and needs of these people. Dr. Ba was talking about Senegal, some of the initiatives, including the master plan and all of that. We've done this. The West Africa Drug Policy Network has been part of policy reform, drug policy reform in Ghana. We've been part of it in the Gambia. We've been part of it in Liberia. We've been part of it and tried to influence part of that in Sierra Leone. So we support policies and initiatives like the harm reduction initiative, some of the needle and syringe programs. We support the drug consumption room environment in Ivory Coast and all of that. So we have to support. That's putting people first. It means because these policies put them first and it considers them, that's the reason we support them. So it's also very key. Inclusive decision making. The West Africa Drug Policy Network, as at that time, we have ensured that we engage the community, whatever community. In this case, especially for this project, people with diverse sexual orientation, we have sex workers, we've engaged people who use drugs. We create this community. We make sure they're involved in our decision-making processes. So part of the advocacy for this is we want the recognition and inclusion of people who use drugs, sex workers, and people with diverse sexual orientation at the ECOWAS level. They have to be involved, because when regional decisions are made, when regional policies are put together, they have to make contributions to that policy and those programs because it affects them. So if you're listening to me and you are considering putting people first, or you run a program, an initiative that have to do with minority groups, vulnerable groups, these are things you have to start considering. They have to be engaged throughout the process of your advocacy or your education. I spoke about active listening. That's part of the engagement. We want to hear what these people are saying. I remember 10, 12 years down the line, I used to do advocacy for, I used to work on SGBV projects, right? We advocate to minimize the acceptance, the level of acceptance for physical and other forms of violence, economic violence, psychological violence against women. Interestingly, one of the communities where I worked, we had a research around reducing the acceptability of physical violence particularly. During the research, we found out that, yes, in that setting where we did the research, the culture there is that women believe that physical violence from their male partner is a way to express love, is a way to express concern. So for them, they liked it. They wanted to be physically assaulted and abused. You see, so that's listening to the community. We have engaged people who use drugs from rehab facilities, while some of them were saying, oh, I'm recovering because of the effective prayer and regular prayer sessions at the rehab center, and not necessarily the therapy, right? And somebody else came and said, no, I don't gain and benefit, I don't recover by mere prayers. I need medical assistance. So listening actively to the communities will help you effectively put people first. Access to resources. You know, At West Africa Drug Policy Network, whilst we were advocating for policy reform, we observed and noticed that policy reforms really take a long, long time. So we asked ourselves, are we going to sit back and wait until these laws are reformed? In the interim, whilst we're advocating for policy reform, how do we ensure that people who suffer from drug use or problematic drug use, or people who need support, how do they get this support along the line? How do we ensure that they are not discriminated against? How do we ensure that they have access to quality service whilst we're waiting for these policies to change? So putting people first is also key, that whilst you are arranging out on policies and advocating for that, you ensure they have access to some of these services. It's very important. That can happen simultaneously. Facilitate connections to resources, like we said, social services, you understand? And so there are times all these people use drugs. We observed some time back in one of the West African countries, all they needed was vitamins. They needed paracetamol. They needed malaria treatment. Right? They had to heal their wounds. And those ones are not criminalized. So which means whilst you're trying to put people first right from that point, you make sure these people have access to social services if you can. This is also very important. Skills, life skills. How do we train them? How do we ensure some of them are prepared for jobs? How do we ensure some of them can really even articulate their own issues? So small workshops. Before now, because there are some laws in West Africa with regards to drug laws that even criminalize the gathering of people who use drugs. So it made it very difficult to talk about workshops, training, and because you can't converge, you can't convene them. In some of these laws, it's criminalized, right? But we need all of this to empower them, because there are some who can also be very productive members of our society. Mentorship, which is almost the same. We want to create mentorship. You want to keep an eye on them. It's putting people first. Mentorship is also very key. We want to also ensure that we foster inclusion. Diversity is key. We want to create an environment where we also ensure that as much as we have a group or a community of people, for example, people who use drugs or sex workers, we have to understand that they may have come together with different needs and concerns. So when they come into those spaces, we ensure that we make sure they are at home and their contributions are valued. Absolutely, we cannot work in isolation. We have to consider intersectionality to promote collaboration. I think in the most recent years, we have seen a lot of consortiums, we've seen a lot of coalition emerge, right? Because the more, the merrier, and it helps us with diversity. I've just said this individual needs may have diverse needs. As we come together, they have different needs. We have to pay attention to that. We have to stay responsive, that you have to really be reliable when you are dealing and supporting these groups. You must be willing to adapt programs based on feedback and changing circumstances within the community. So you cannot say, oh, we have already planned our way, we've already determined this, we've already met with stakeholders, we've already presented this idea to stakeholders, and therefore it cannot change. No, we have to be responsive. We have to make sure we adapt programs to feedback. And that's the reason why I want to interact with the community and listen to them. There's also access to health services. But most importantly, we have to create a safe space. Establish environments where individuals can express their feelings, their deepest of feelings. They have to trust you and experience without judgment. This is an environment that we can all create. People who use drugs, people with diverse sexual orientation, sex workers, who are the groups that the West African Drug Policy and other members of this platform operate with and deal with and advocate for, they've already been stigmatized largely. They've been criminalized as well. So we have to work hard on creating an environment where these people can come and share their concerns without fear of being judged. That's how we put people first. Of course, we can leverage on technology now to provide resources, to provide support, to provide information to this group. Right? Online programs, we shouldn't forget about that. In all of our projects, let's see how we can explore and leverage on digital platforms and online communities to bring them together. I mean, we have to monitor progress and we have to look out for feedback at all times for our intervention. We have to make sure that people actually feel inclusive, they feel included, to ensure that they participate, their participation and their representation is actually adequate and satisfactory. And that's the reason why we follow up on feedback so that we can adjust our interventions. Thank you very much, ladies and gentlemen, for lending me your ears and your attention. These are just some of the considerations we could have if you want to put people first. These are some of the things you have to think about in your project. These are things you think about in your organization and also in your programs. Thank you very much for listening. I'm open to comments and questions, and I'll be available. Thank you very much, Michael.
All right. Thank you. Thank you very much, Princess, for this wonderful presentation. Okay. So I would like to ask colleagues if you have any questions, comments, or suggestions. After that, we would have a general comment from all of you. The floor is open. Okay, let me check if we have any comments to read out loud. Okay, so all I could say in the comment section is thank you very much for informative presentation to Charity, and also we're saying thank you to Prof. Idris Abba for your insightful and informative presentation. So that being said, I would like to open up the floor for general comment, just as Habib was trying to make. For other colleagues who also have something to add, the floor is open for you to add. Okay, so in the absence of that, I would like to call on Professor Zaba. If you have anything to add, probably a few follow-ups or your remarks.
Okay, good afternoon. Sorry, I was struggling to come in. Okay. Good day. I'm Santracha from Enugu, Nigeria, and I'm glad to be a part of what is happening and the conversation. I'm a part of the organization here in Nigeria, and we've been following, and I'm so excited about this decriminalization of drug users, because of course we can see from every angle that punishment have not achieved so much. So I am fully in support, and I'm also working with a few of them that have actually left drug and becoming better individuals. So I actually just want to commend this effort and say we should intensify. We should not stop yet, because there are a lot of people that we could recover by being caring and loving and more understanding, and combining all that you just mentioned to taking care and looking out to us, of course, beyond their mental health, but also their physical well-being. So thank you so much, and God bless you.
All right. Thank you very much, Raphael, for your contribution. Okay, Paul, I can see you for mute yourself. You can add your voice. Paul, you have to unmute yourself.
On that. Thank you. My name is Paul Atai. I'm the Executive Director of Drug Abuse Prevention Awareness Initiative, Benue State, Nigeria. I'm also a member of West African Drug Policy. What you are doing, team has been doing. We've done a lot here. We've been working with key population who use drugs for over 7 years now, and harm reduction, which is the way forward now. We've been trying to educate them so they can recover without complications, because a lot of them are polysubstance abusers. They combine multiple drugs, so stopping at once becomes a problem to them. And with the training that we've been receiving from West African Drug Policy Network, collaboration with Youth Rights Nigeria, we've been able to initiate a replacement therapy, and we've been able to help them recover. So we want to appreciate what you're doing and the team, and we're working together to see if we can include other vulnerable people too who use drugs. So thank you so much for what you're doing. Cheers.
All right. Thank you very much, Paul, for your kind words. It's very important that we include everyone, because nothing about us without us is actually something that we would have to embrace. As the presenter or one of the speaker friends mentioned, that it's not just a slogan. It has to be an action attached to it for us to achieve our goal in West Africa and beyond. So the floor is open. Habib.
Yeah. Good morning
Okay.
again. Like Paul just concluded saying, we should take harm reduction very serious in West Africa. For us, harm reduction is cost effective than a primitive approach that government has been taking right across Africa. With a harm reduction program in Sierra Leone, majority, let me say 85% of those that works for my organizations were drug users. And with the past time, harm reduction has really established them to be a well-meaningful Sierra Leoneans. And they are now working with their contemporaries who are still on it. So harm reduction really needs to raise it as West Africans, and we try to advocate to ECOWAS to take it more serious and to take the Dakar Accord. The Dakar Accord, which came in about 2016, which says you should not leave any population behind in terms of reaching out to that person in terms of health activities. So we really need to campaign our government, and more especially the regional body, which is ECOWAS. And as you all know, ECOWAS is the regional base and is the regional organization. And Sierra Leone is undergoing this food crisis. Recently, there has been an ECOWAS team that was sent to Sierra Leone to really come and understudy what really is going on. And I want all African countries, more West African countries, for all of us to try to work and try to give a true and West Africa and drug policy. And the West Africa drug policy really needs to write a position letter or a position statement to the ECOWAS that this has been, for the past 5 years, the West African Drug Policy Network has been working with civil society organizations for us to try to have our various drug policies. I think if we move with this channel, I think all other countries will join, all other countries that has recently has their own drug policy. As for us, Sierra Leone, we are advocating for the review of the 2008 drug law. For us, it is obsolete and it discriminalizes the users. And we are advocating for harm reductions to be part of the next review, which the Ministry of Health is supporting and which the Ministry of Internal Affairs too is supporting. And the Ministry of Internal Affairs are responsible for drug regulations. And I want to say thanks again to Prince Boone, coming from the West Africa Drug Policy Network to the National Drug Law Enforcement Agency. And we think that the National Drug Law Enforcement has more capacity in terms of advocating for the review of drug law. And he being part of the current administration, I think Sierra Leone will achieve what we are calling for. So I want to say thanks to other colleagues. And again, we are more than this population that is on the meeting today. Let us try and call other members for us to have one synergy to see what we have started to be a reality. Thank you so much. Thank you, Paul. This is my first time of seeing you. So let us have the bond and let us communicate after this. So I will share my number with you. So let us take it from there.
Okay, thank you. Thank you, Habib, for your wonderful comments.
Yes, thank you.
Let's also reiterate some of the things you said. You mentioned that the West Africa Drug Policy Network should actually send a statement to ECOWAS. As part of this project, just to mention that we have been engaging ECOWAS, and we have also submitted a communique to ECOWAS for their consideration, particularly for the inclusion of these three communities in decision making in any other decision that would be taken on their behalf, still affirming not leaving anyone behind. Thank you very much for your comment. That being said, I would like to call on Dr. Ba to give us his closing remarks and any other follow-up that he has. Dr. Ba. Okay, so in the absence of that, I think Dr. Ba is trying to unmute himself. In the absence of that, I would like to call on Prince to give us your closing remarks.
Yes, Michael, thanks for calling up again. Habib and all the other speakers. And I want to thank, of course, all of us who are on the platform right now and encourage all of us to use this information that we've received today to continue to advocate, to continue to put people first, especially people who use drugs, sex workers, and those with diverse sexual orientation. There are a lot of challenges on the ground, of course, from funding to the political will, and also enhanced understanding by even those who are affected by these problems. But we shouldn't give up. Let's keep pushing. Let's keep exploring every little opportunity that we have. I mean, we could also go, it's less expensive to use technology and probably social media platforms, but we have to keep pushing until we break through and make sure that marginalized groups are considered in policy making, are considered in the project implementation, project design and implementation, and any other program that would affect them. Thank you very much, and I hope to see you guys again in probably our next session organized by the West Africa Drug Policy Network and Michael. Thank you very much, guys.
Thank you. Thank you very much, Prince, for your remarks. Dr. Ba, if you can hear me, the floor is yours to give your closing remarks. Okay. Technology is kind of some way, so sometimes we just have to accept that we can't always control everything. In the absence of that, I would like to say a very thank you to everyone who joined this webinar. It's a pleasure moderating this. And just to also tell our colleagues that this is not going to be the last. We are hoping to have a collaboration with the ECOWAS, having a representation over here to just give us a rundown or give us some of the things that they are doing in the region and how civil society in the region can also play a role in it, making sure that everything that we want to achieve in the region is being achieved. In the absence of any other thing, let me go to the chat and then, okay, so Michael, okay, is saying that thank you, Prince D, for your presentation. Okay, thank you. Thank you also. So in the absence of any other comment, suggestion, questions, I guess this is the end of today's webinar, and I hope to see you in our next webinar as well. In case of any engagement, you can just follow on us. Go to our website, www.wadpn.org, or you can also send us email, info@wadpn.org. Thank you very much for joining, and I wish you all a very great day. Thank you.